Today we'll discuss about tracheal strictures and tracheoesophageal fistula and its management. So we'll review the clinical presentation of patient with tracheoesophageal fistula, understand the prevalence and types, and discuss the diagnosis of tracheoesophageal fistula, describe the medical and surgical management of this condition, and understand the anesthetic related implications and develop in the anesthetic plan. The tracheoesophageal fistula is an abnormal connection between the upper gastrointestinal tract and the respiratory tract. It occurs sporadically in 1 in 3,000 live births, and no references between the age and sex. And 20 to 40% of the infants with tracheoesophageal fistula are born with premature and or small for gestation. The associated syndromes with other congenital anomalies is 20 to 50%, 20 to 35% of with congenital heart defect, and 16 to 24% with gastrointestinal anomalies, and 15 to 25% with renal and genitourinary anomalies. And it's also associated with trisomy syndrome. VACTERL syndromes include the vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, and renal anomalies and limb complications. So to understand that, we have to learn the embryogenesis, incompletely understood but proposed to be foregut formation, and the tracheal esophagus develop from the foregut in 4th to 5th week of gestation, and during this time the trachea does not separate from the foregut formation correctly. So one has to understand the ventral bud formation and the trachea and how it is formed and what are the implications. So there are 3 different types: type A, B, and C. Sorry, 5 different types: A, B, and C, and D and E. And the management depends on the type, and they are difficult to diagnose and some are difficult to manage as well. So differential diagnosis include the gastroesophageal reflux disease, aspiration, and obviously the tracheoesophageal fistula. So one has to understand that the patient who are at risk, especially if we are talking of the acquired tracheoesophageal fistula, obviously in neonates we can diagnose because of a risk of congenital formation, but in adults it's difficult to diagnose sometimes. And the risk factors which can cause tracheoesophageal fistula in adults include the steroid therapy, diabetes, immunodeficiency, infection, the prolonged ITU admission, intubation and ventilation, trauma, caustic injection, foreign body ingestion, and instrumentation, iatrogenic injury, tracheal lesions, tracheoesophageal surgery, granulomatous infections, and high cuff pressures can cause tracheoesophageal fistula that can impair the mucosal blood flow with the concurrent presence of gastric tube that can contribute for development of the tracheoesophageal fistula. So in ICU, one has to take care of these patients very well. If the patient is intubated and ventilated, the bilious secretion in the case of ileus or the tube feed or the endotracheal tube or the tracheostomy or the gastric dilation can cause the loss of tidal volumes, and these signs may suggest the tracheoesophageal fistula. In non-ventilated patients, the tracheoesophageal fistula include persistent cough, fever, dyspnea, recurrent pneumonias. Chest X-ray may show contrast stopping in the esophagus. OGT is curl in the esophagus, and the gas bubble in the stomach passes through the fistula of the stomach. So one has to keep the patient ill by mouth, upright position to minimize the regurgitation, and minimize the regurgitation of the gastric contents, and intermittent suctioning and correct any electrolyte imbalance and consider antibiotics. If the patient requires mechanical ventilation, then repair or gastrostomy may be urgent. And there is high expiration risk. Air will travel through the fistula to the stomach. That has to be addressed. And pulmonary complications can arise from aspirations and in neonate small blood volume and challenging airway, and there is higher resistance to the pulmonary. And complete preoperative assessment has to be done and rule out other abnormalities, including echocardiogram, renal ultrasounds, and the cross-matched blood multidisciplinary approach should be taken into account. There's a Watterson and Okamatsu classification system that can be used to determine when and what type of surgery should be done. Depends on the prognostic factors such as patient comorbidities, weight, and other anomalies, and determine in the case if this case should be done urgently, completely repaired in one surgery, or have the stage repair, and may have open thoracotomy or thoracoscopic repair with insufflation of CO2. A bronchoscopy from tracheostomy is transnasally or orally could be performed to examine the trachea and see what the lesion is, and the diagnosis can be confirmed and a plan of management can be made. Esophagoscopy is also helpful in sometimes. Spontaneous healing is rare in tracheoesophageal fistula, and surgical intervention is sometimes needed. And in the operation, the step is to minimize the swelling of the airway. And as we discussed, we need to elevate the bed, and tracheostomy cuff should be repositioned. The adjustable flange of the tracheostomy tube or distal extra long limb can be used, and the effort should be made to wean the patient from the ventilator, as a positive pressure provided by the ventilator helps to keep the tract open. The patient who are intolerant to the non-operative management covered with the tracheo-esophageal stents can be utilized as temporizing measures and early healing, particularly when both the tracheal and esophageal stents are used for the radial forces placed between the unwanted pressures on the area of communication. Stenting should always be used with caution, and those who are experienced in performing these procedures. And once the patient is optimized, an operative plan can be made, and the preoperative strategy to ventilate the patient needs to be made. And the fistula is small, it will not require the tracheal resection. But if it is large, then one has to do the resection with low tidal volume, distal high frequency ventilation, doubling lung ventilation with distal airway isolation, cardiopulmonary bypass can be utilized. In these cases where the primary repair or simple resection is not possible, or exclusion, the esophageal perforation is there, then operation is performed as a last resort. And when we are operating, we give the incision in the neck and divide the muscles, identify the fistula, and we need to debride the unhealthy tissues. And membranous tracheal defects are closed, and the esophageal defects is closed in 2 layers as well, and we can utilize a flap. And if you have to do the tracheal resection, then the same sort of approach is applied, and the trachea is divided proximally and the fistula is resected with the esophagus. Esophagus is repaired in layers with a muscle flap, and trachea then reapproximated, and a neck stitch can be applied, and endotracheal can be tube placed to the distal repair. So there are different conditions in which we have to consider a lot of other problems, and every case is different and should be managed accordingly. So the primary complete repair, the fistula is managed and ligated. Esophagus is anastomosed in the stage repair. There is a risk of high risk patient who cannot tolerate this thoracotomy, gastrostomy, fistula ligation or occlusion can be done, and may need intermittent surgeries and esophageal anastomosis at around 3 to 6 months of age. There can be many events, intraoperative events and the cardiac events. So the patient who have a lot of problems, they are not amenable to the closure, or the fistula is too large. The management strategies could be with the dissection of the esophageal rim, and the esophagus can be reapproximate to recreate a membranous trachea, and esophagus closed in 2 layers. And if a patient is found to have a large uh, bronchoesophageal fistula, then the distal trachea, carina, and both the main stem can be approached by the right thoracotomy sternotomy, and the defect can be resected, repaired in these steps, and the extra length is needed to obtain the tension-free repair. Postoperative management depends on the procedures and the patient's condition, and the patient is extubated and kept intubated. Most patients may require ventilatory support due to the lung disease, tracheomalacia, inadequate pain control, avoiding emergent repair, and need for suction and expansion of the lung, and transanastomotic tube can be placed to protect the repair. And one has to keep the head in neutral position to prevent the stretching of the esophageal anastomosis, and this position could lead to prolonged stay. If the biopsy reveals a cancer, then the management of the tracheoesophageal fistula is associated with esophageal pulmonary tracheal cancers, and one has to do the endoscopy, take the biopsies, and determine either it's a recurrent cancer, malignant tracheoesophageal fistula, often the sign of the advanced disease with poor prognosis, and the survival rates of less than 10 to 12 months. And such a management is geared towards the palliation, avoiding the significant mortality. Covered with the tracheal and esophageal stents are often reasonable management. Esophageal exclusion, and with the end of cervical esophagostomy and gastrostomy due for this decompression, and the feeding jejunostomy may only be an option, and in some cases to prevent the ongoing soiling of the lungs. Esophageal exclusion and bypass is often associated with significant morbidity, and it's generally not a good idea, and the palliative options often coexist. The outcome, the tracheoesophageal fistula mortality rates is related to the severity of the associated congenital cardiac anomalies. With the birth weight, lower birth weight is associated with higher mortality, and a coexisting major cardiac anomaly is associated with the higher mortality. So, if the fistula associated with the tracheostomy, and the patient develop a bleeding around the tracheostomy, then obviously we think of the mucosal irritation, suctioning, and tracheitis is suspected, and there could be bleeding, tracheal granulation tissue, alveolar hemorrhage, and tracheo-innominate fistula can be there. And the tracheo-innominate fistula is caused by the erosion of the endotracheal tube and eroding the innominate artery. And sometimes there is overinflation, and the cuff balloon may temporarily tamponade this bleeding, and sometimes one has to do the operative surgery. The choices of repair is simple ligation, resection of the affected artery, and the direct repair of the defect and the bypass. The early complications are anastomotic leak, esophageal strictures. There could be tracheal diverticulum, esophageal strictures, gastroesophageal reflux disease, respiratory disease, tracheomalacia, and neuromuscular anomaly. So, if the patient develops the tracheal stenosis, then One has to investigate with the chest X-ray, dynamic CT, laryngoscopy, bronchoscopy, and pulmonary function test. And any patient with the history of endotracheal intubation developing the symptoms of the airway, wheezing, stridor, or the exertional dyspnea should be investigated for an obstructing tracheal lesion. Stomal stenosis is caused by the enlargement of the tracheostomy, eventually healing to the granulation tissue. As the granulation tissue contracts, it narrows the tracheal lumen. The stoma can be enlarged due to the leverage forces and the equipment attached to the tracheostomy, and a large tracheostomy at the time of insertion or infection, and the patient may prevent the late or may have not regained the enough functional activity or maintain the airway of obstruction. For the patient to be symptomatic at rest and the tracheal diameter is typically less than 30% of normal, having the patient extend the neck and inspire rapidly may elicit the stridor. And diagnosis can be made by the laryngoscopy, which should be carried out prior to the more invasive procedures requiring anesthesia. The bronchoscopic evaluation for the tracheal stenosis should be undertaken in the operating room with a careful planning preoperatively and the surgical and the anesthesia team. The patient should initially be evaluated awake, and the local anesthesia and the anatomy should be confirmed with the intravenous anesthetics is provided without the muscle relaxants until the airway is controlled. When there is a requirement of the suspension laryngoscopy or the rigid bronchoscopy, the glottis and the vocal cord function should be assessed in addition to the stenosis. The tracheal lumen is less than 5 mm in diameter. Dilation can be performed with the graduated Jackson's dilator, and this can often be provided with the temporary relief and which can allow the delay of operation until the tracheal mucosa is healed and the patient is medically fit for surgery. If the stenosis is larger than 5 mm, the bronchoscope should cross and will provide the dilation. The gentle insertion of the tip of the bronchoscope into the stenosis with the rotatory motion with the light pressure typically allows it to advance the past stenosis. Other interventional pulmonary techniques allow the balloon dilation, stenting, boginage, or anti-YAG laser debridement can be used, and the option could be discussed. If you suspect the vascular problem, ischemic injury, then the endoluminal therapies are not curative, and definitive treatment is resection and need to have an aesthetic plan. For these patients who cannot tolerate the resection or who have a long strictures, who are amenable to resection and reduced tracheostomy may be needed, and care must be taken to show that the distal end of the tracheostomy is distal to stricture, and the tracheostomy can eventually be exchanged to the tracheal T-tube, and often a silicone T-tube is passed through the tracheostomy and the stoma and the three limbs. The shorter proximal limb is directed toward the vocal cord, the longer distal limb is directed toward the carina and should pass the stricture, and a shorter limb passes externally through the tracheal stoma. When the external limb is uncapped, the patient can then inhale, exhale through the T-tube, and when the T-tube is capped, it acts as a stent covering the strictures and allowing the patient to breathe and speak normally. And it's important to measure the distance between from the vocal cord to the stricture and the form of carina and stricture. The T-tubes with a varying limb and lengths are available for custom T-tubes and can be ordered from the manufacturers. And it's important to make sure that the limbs are not too long, as uncontrollable coughing will be caused by irritation of the vocal cords and carina. The T-tubes provide a good long-term options for inoperable patients as they are better tolerated than tracheostomies, and rarely it causes stricturing and allows the patient to speak and breathe normally. It is important to note that the patient with T-tubes cannot be placed on the mechanical ventilators, as a significant amount of tidal volume will escape proximally into the nose and mouth. The tubes are pulled out of stoma. It's easy than the cuff tracheostomies. So, and there's a risk of there's a little risk of migration. So, in order to operate, one has to incise and do the dissection, prevent the protect the laryngeal nerves, and trachea should be mobilized, and stenotic segment can be identified, and bronchoscopy and transillumination can be performed, and the distal airway can be intubated with a sterile endotracheal tube, and ensure that there is a tension-free anastomosis, and the anastomosis is most commonly done with the PDS, and then the patient could be managed in the ITU. In most of the surgeries, cervical flexion will provide the enough tracheal length, and if there is a tracheo-innominate fistula, then the innominate artery should be mobilized. And if there is a critical tracheal lesion, that increased risk of obstruction from the minimal amount of secretions. And the post-intubation cuff lesions, which occurs at the level of ceiling cuff, the radial pressure exerted from these cuff could cause pressure necrosis. So these can be again treated with topical application of mitomycin, YAG laser, and T-tube placement. I hope you enjoyed this presentation, and if you have any comments, please feel free to pass it on, and hope to improve the presentation in the future. Thank you very much for your time and patience.